Dear Chairman, thank you for this invitation to present to the EBC meeting 2021. The title of my presentation is Comparison between POT side RePOT and POT final kissing balloon inflation for final stent eccentricity and minimal lumen area, insight from OCT-guided LM PCI. As we all know at the EBC, the use of POT is mandatory for the management of bifurcation lesions, including left main, but we don't really know what is the exact optimal subsequent sequence to apply. Bench and computational data suggested that the POT side RePOT strategy could be better in terms of efficiency and stent deformation. For example, this work from Gerard Finay's group showed that the use of the POT side RePOT sequence reduced the ellipticity index and the percentage of malapose struts in a bench when compared to the POT kissing inflation. However, we don't really know if these ex vivo data are really could be translated to clinical practice, and their acuity remains to be determined. In this perspective, we think we can use intracoronary imaging techniques to further analyze the impact of the different techniques on the final result. The aim of the present study was to compare the effect of POT side RePOT and POT final kissing balloon inflation techniques on the final stent eccentricity and the minimal stent area in a cohort of patients with left main PCI guided by OCT. These patients came from the Lemon trial. That was a prospective multi-center single-arm trial that analyzed the feasibility of OCT guidance for left main PCI, and thus included patients with stable or non-stable distal left main lesion and or ostial circumflex or LAD lesions that were treated by PCI. The OCT guidance was provided by pre and post PCI runs, but the choice of the PCI strategy was left at the discretion of the operator. This slide reminds you the design of the protocol, and for the subsequent analysis, we only use the pre-PCI and the post-PCI OCT runs. On the pre-PCI run, in addition to what we measured in the main trial, we also analyzed the proximal landing zone, as you can see here, and we determined the eccentricity index, that was the ratio between the maximal luminal diameter and the minimal luminal diameter. We redid the same eccentricity measurements in the post-PCI run on the section of the stent that was implanted in the left main, and we thus defined three different sections. The first section, S1, was the proximal edge of the stent, and that was the equivalent of the proximal reference segment. The third section, S3, was the most distal section before the polygon of confluence, and the second section, S2, was a section that was equidistant to S1 and S3. And as you can see here, we measured once again this eccentricity index. There were a total of 70 patients included in Lemon. 37 of them underwent the POT side RePOT sequence, whereas 33 got the POT final kissing balloon inflation sequence. The baseline characteristics of these patients are presented here. And you see that the patient from the final kissing group had a better left ventricular ejection fraction at baseline, but they also had higher incidence of true bifurcated lesions. Of course, the final kissing was used in all patients with a two stents technique. But this patient represented the minority of the patients included in the overall cohort. Moreover, there was no significant difference in terms of dimensions for the main stent and the POT balloon used in the PCI. These are the OCT characteristics of our patients. The patient from the POT final kissing balloon inflation cohort, a group, had a higher incidence of any calcification on baseline OCT that suggested they got more complex lesions, but there was no difference between the two groups in terms of maximal or minimal luminal diameter. There was no difference into the baseline luminal area on the proximal reference segments, and moreover, no difference in terms of baseline eccentricity. This slide shows you the eccentricity and maximal luminal diameters in our patients, and you see that more than 80% of our patients got a significant eccentricity at baseline, and around 1/3 of a patient presented a marked eccentricity with a ratio over 1.3. There was no difference between the two groups. Moreover, a maximal diameter of the proximal segments over 4.5 was present in 50% of our patients, and more than 20% of our patients got a really large left main with a maximal diameter over 5 millimeters. There was no impact of the sequence on the final minimal stent area that we measured, but we observed that there was less eccentricity in the distal part of the stent with the POT side RePOT sequence compared to the POT final kissing balloon inflation sequence. This difference was not observed in the most proximal part of the stent, the S1 section. Moreover, when we compared the evolution of the eccentricity between the reference segments and the section, S1 section pre and post PCI, we did not observe significant difference in the overall cohort and in any of the two groups. Finally, we did not observe significant difference in terms of the final malapposition. You see that there was around 20% of our patients that presented a significant malappositions, and there was no difference in terms of dissection. In conclusion, these sub-analyses from the Lemon trial showed that the left main marked eccentricity and large diameters were present in a significant number of patients at baseline. The POT final kissing balloon inflation sequence was used in more complex lesions and was associated with more eccentricity in the distal part of the stent, but it did not really increase the vessel baseline eccentricity. There was no impact of the technique on minimal stent area malappositions or dissection. However, we think that more data are needed, and especially data from randomized trials are required to draw a final conclusion. I thank you for your attention.